Ladies and gentlemen, my name is Eva Škarlová and I am currently working at Glaucoma Center of Ophthalmology Department in General University Hospital in Prague. Allow me to present a short lecture about secondary uveitic glaucoma. Secondary uveitic glaucoma is defined as elevation of intraocular pressure in patient with uveitis, which leads to optic nerve damage, RNFL changes, and causes progressive visual field loss. Secondary glaucoma develops in 10 to 20% of patients with uveitis. In chronic inflammation, the rate can reach up to 46%. Incidence can also vary according to the type of uveitis. In pediatric population, the incidence of uveitis is approximately 5 times higher than in adults. Secondary glaucoma develops in 5 to 13% of children with uveitis. It is sight-threatening condition with poor prognosis, especially in early development. Several mechanisms can cause secondary glaucoma. Firstly, it is the inflammation itself. Secondly, corticoid therapy. Inflammation can damage and remodel trabecular meshwork. Meshwork can also be obstructed by inflammatory cells. All these mechanisms lead to increased resistance in outflow pathways. Furthermore, inflammation can cause formation of posterior synechiae and angle closure. Corticoids cause trabecular meshwork edema. Furthermore, they play a role in inhibition of phagocytosis of trabecular endothelial cells. This process enhances the accumulation of cells, protein, and detritus in outflow pathways. Secondary uveitic glaucoma in year-associated uveitis is sight-threatening condition. Often, it is difficult to differentiate between inflammatory and steroid component. In more than 1/5 of children treated with corticosteroids, secondary glaucoma is present. The therapy of secondary glaucoma in year-associated uveitis is aiming to reduction of intraocular pressure. At the same time, anti-inflammatory treatment is used to minimize intraocular inflammation. Systemic anti-inflammatory and immunosuppressive therapy is used to control the underlying disease. Surgical treatment is reserved only for refractory cases. Choice of surgical approach depends on previous surgeries. High risk of postoperative hypotonia and scarring in comparison with primary open-angle glaucoma must be taken into account. Good control of inflammatory activity is necessary for success. According to the literature, eye should be calm 3 months prior surgery. There are several surgical approaches. Trabeculectomy is gold standard. Use of antimetabolites is highly recommended because of already mentioned risk of scarring. Other options are drainage implants, which have similar results as trabeculectomy. Recently, minimally invasive surgery have been developed as a safer alternative to conventional filtration procedures. However, there is still insufficient data to assess the effect of minimally invasive glaucoma surgery in secondary uveitic glaucoma. Angle surgery, such as goniotomy, can be a plausible option as first treatment of children. In refractory cases, even to surgical treatment, cyclodestructive methods can be used, but their pro-inflammatory effect must be considered. Between years 2018 and 2022, we operated 3 children with secondary uveitic glaucoma and year-associated uveitis. Mean age at diagnosis of year-associated uveitis was 3 years. Glaucoma developed in average after 16 months after first ocular manifestation of uveitis. Mean IOP before surgery was 32.3 mm mercury. We performed 2 trabeculectomies with collagen implant, 1 trabeculectomy with collagen implant and mitomycin, 3 anti-glaucoma drainage implants with mitomycin C. Complete success was reached in 3 eyes, which are without anti-glaucoma medication. 3 eyes require anti-glaucoma medication, but the IOP is controlled. 2 eyes of 1 patient required repeated anti-glaucoma surgery and additional laser therapy. Next slides demonstrate photographic documentation of our patients. On the first photograph, you can see cataract and seclusion of pupil caused by the inflammation. On the second one, there is inflammatory activity in the anterior chamber. Next photographs demonstrate surgical iridectomy and glaucoma drainage implant and healed bleb. These photographs are showing bleb shortly after trabeculectomy with collagen implant. In conclusion, I would like to say that secondary glaucoma is a common sight-threatening complication of juvenile associated uveitis. Trabeculectomy or drainage implants, both combined with antimetabolites, are effective treatment of this type of glaucoma. However, we see higher failure rate and higher complication rate than in primary open-angle glaucoma. Adequate inflammation control during perioperative period and individualization of the surgical technique is crucial. Thank you for your attention.